Okay, Amanda?
Yeah.
Okay, so a couple of housekeeping items. If you do have questions, we're going to try to get everything covered in the next hour that we can. Usually we have some time at the end for questions, and then also what I do is I pause throughout, and so does Doug, as we're going over slides to leave a little bit of time. If you have a burning question on a particular slide, go ahead and pop it into the chat box, and we'll try to address it and weave it into the session so that we're answering your questions as we go. The other thing I wanted to ask you for, everyone on the call, if you would, I know they can be a pain in the butt, but we do have a survey. At the end, it's through SurveyMonkey, and we'll send it to you at the end of the session. It's only about 10 questions. They're pretty clear-cut and simple to answer. A lot of what the survey is asking, though, is not just what did you think of this session today in terms of the goals getting covered, but what would you like to hear more about in the future? Because we have a lot of resources, we have a lot of history and knowledge we want to share with you. But we want to know what's important to you. And so filling out the survey helps us understand that, because a couple of questions, aside from whether or not you want to hear Crowded House or Steely Dan the next time, you know, some of the questions allude to, hey, what do you really need to learn? Where are there gaps? What do you want to know more about? So please do fill out the survey when we're done with the session. Tamara will send that around to everybody. So those are just our housekeeping items. Any immediate questions before we get started in the chat box, Tamara, and everything sounds and looks okay?
All good.
Fantastic. So let's talk a little bit about us. We're not going to go on too much about us, because we've got a website and all that handy dandy stuff that everyone has when they're trying to research an entity or an organization to learn more about them. But there's a couple of key things that you should be aware of about Patient360 in terms of us being positioned as both a qualified registry and a QCDR. So we are both. We're actually one of the first original 16. And I think that, you know, I mean, that's dating back to, we're going back to 2006 when this program was first launched as PQRI, and then it sort of morphed and evolved into PQRS with the value-based modifier and meaningful use. And now we're all under the MIPS program, as you all know. So it's quite a bit of change since 2006. And I think having that historical knowledge brings a lot of continuity. And so I think that's something important that we like to talk about when we're discussing, as an entity, as an organization, the amount of time that we've spent collectively working with this program and working with CMS. It's really significant, and it really does provide you as the client or the group, if you're planning on potentially co-stewarding with us for QCDR measures, quite a bit of continuity, and you can be confident that we really know what's going on behind the scenes. And another thing to be aware of when we're looking at, you know, about us, you know, what makes us unique or what's really important to know is, you know, QCDR measures, it's not easy to just put together a QCDR measure. There are a lot of steps involved that we're going to go through today on this call, and what that looks like and how to go about doing that. But I think that it's important to be aware that because we have the program continuity, a lot of times if you're dealing directly with CMS, as many of you know, the government they don't just respond to you. They have multiple contractors in multiple different areas. And that can get really difficult, because typically they're recontracting with new organizations or entities every year. Whereas when they're working with registries like us, we've been the same registry for the last, 16 odd years. So we have the ability to answer questions that a lot of the new contractors, when they're coming on, the QPP says, well, we can answer questions anytime, open a ticket with us. Understand that a lot of times when you're receiving an answer from QPP Ticket House, essentially from that tier, that's a new contractor that just started this year. They may or may not have legacy program knowledge. They may or may not have program knowledge for the question that you're asking. So we ask a lot of our clients, come to us first, or take a ticket that you've opened with QPP and bring it to us, and we will check it with federal regulations for you, because we really are well versed in statute. We understand the final rule. Everybody on our team is extremely well versed in that. So just want to point that out, that if you really need to understand something about the program rules, how to get started, what to do, come to us, because sometimes just giving you that little inside tip, new CMS contractors are just that. They're new, and it's not their fault that they get recontracted every year, but it is a system and it is what it is. So just encouraging you to come to us when you have questions. So a little bit more, one more time, about the agenda. Now, there's 4 agenda items that we're going to cover, and I always like to level set and say, look, here's the goals. What do I want you to walk off? What do we want you to say? Hey, I understand this when I walked off this call. This makes more sense to me. And that's part of what you're asked in the survey too. did the call cover what you were trying to understand, and what don't you still understand? What do you still need to know more about? There are 4 items, but I'm going to tell you that number 2 is going to be the one that we're going to focus on the most, okay? Because this is really, today's call is about being a QCDR, about using QCDR measures, about the history of the QCDR, how they came about, what the measure development lifecycle looks like, how to co-steward and to become a QCDR with Patient360. So we're going to spend most of the time on that. So just want to set expectations for that. Of course, we're going to go over what the MIPS program is, because in order to understand why QCDRs exist, you have to understand the overall MIPS program first. But we're not going to get into the granular MIPS details, because we actually have other sessions that we've recorded on that. So if you kind of need a brush up on what are the program rules for 2018, 2019, and beyond, we actually have sessions that we recorded, so you don't have to worry about that. You can go back in and check those out, but we will do a broad overview. And then, of course, we're going to go through, once we talk about number 2, what's the deal with the QCDR, how to do it, what it means, what it's all about, what are the options. Then, of course, taking your data, how do you actually apply your data? How do you submit data as a QCDR? And how do you do that with Patient360? So that's what you're going to walk off the call understanding today. And I'm going to pause for a second, see if anybody has any questions at the moment.
Keep on rolling, Amanda.
All right. So Doug's going to get us started with a little bit more about why providers need to report for MIPS in terms of, what it means for you financially. And I think it's really impactful and it's helpful when it's coming from our clinician who has had to deal with this program for many, many years, not just as being co-founder of the registry, but as being a clinician himself, as being in practice, and having to deal with the program and understand how it's morphed and changed and what it means for you. So with that, Doug's going to talk a little bit more about the outcomes and what the expectations are for the MIPS program and the financial implications.
Sure. Thanks, Amanda. So this is a really sexy and exciting topic. I'm glad you guys are here spending your lunch with us. And we have a task in front of us to try to make something that is pretty damn boring more interesting, and to explain why people should be interested. The money is definitely a part of why Medicare feels that you will be interested, and what I try to explain to folks is the money is actually more important than just a 4, 5, 7, or 9% plus or minus increase. The reason that's really important is at the end of the sustainable growth rate, which ironically became unsustainable after the first 2 years of its implementation, that we are stuck presently with the the leaving of the SGR. We're stuck at a 2002 fee schedule, and that's what we're being paid upon. So if it feels like you have less money and you're being paid with less money, you are. And the only way that we can try to get even close, maybe to a 2005, 2006 fee schedule, would be, trying to get some of the bonus money that's currently available. And it's really, really frustrating to me that when we have tried to meet in Congress, and not really with the QPP folks, but just in federal Congress, that they don't get it. I've met with federal senators, and I said, how would you like to live and run your office right now, your congressional office, on a budget with adjustments that are 12, 13, 14 years old, and in this case, we have to go back 16 years if you don't get the bonuses. And they said, you can't look at it like that. And I'm like, I'm not sure how the hell else you want me to look at it, because that's what we're dealing with right here. And I think it's really important for us to understand that this isn't just about money, it's about the quality of care that's being provided. Because at the end of the day, this is an awful long time to go to school, to be trained, and to take care of folks just to be worrying about money. We're here to make sure that we can improve the quality of care, improve the lives of the people that we're seeing. And I would venture to say that 99 to 100% of the people get up each day to go see patients do so to make sure that they are going to do the very best by their patients that they can. But the participation is going to impact the bottom line for the practice. And if you are continuing to participate in Medicare, this is something that has to become a reality, but it also is not supposed to work in a vacuum. This was not a silo-driven model that Medicare expected and is hoping that the private payer organizations would get involved, because until they do so, then sometimes people are wondering, well, is it worth just seeing more private pay versus Medicare? I think it will be worth it, because there are private payer organizations that are beginning to move in this direction as we look at the alternative and advanced payment models that are coming out. I think we're going to be seeing a lot more value-based care, and the move from quantity-based, typically the reimbursement was procedures, volume, and that was how we got paid. And if you did more volume, more procedures, you made more money. those days are coming to an end. And not that E&M care or that the ability to get paid for fee-for-service is going to be gone. I don't think that will ever happen because this is America. But at the same time, they're going to be adjusting how much money we're getting paid on that fee-for-service basis if we're going to continue to take Medicare and the private insurance industry. Next slide. So the goal of the program, and I think this is important historically to understand, is that when the Physician Quality Reporting Initiative began, 95 to 98% of costs that could be reduced were based upon services or procedures that could have been avoided, could have been prevented if the care had been better. So when we made these new measures, the intention was not about trying to come up with a program that was going to be harassing or was going to really, make interesting what was going on. It was that Medicare said, gosh, we're spending a lot of money that we would like to not spend. So in the spirit of the program, improving quality is really what we're trying to do. And my dad used to always tell me when I was a kid, don't study for the test, learn the material and the test will come, which when I'm cramming for a test at night isn't very helpful to hear, as helpful as he was trying to be. But the spirit of the program is they want the quality improvement to work and then align with cost savings and align with improved outcomes for patients and hopefully making our jobs easier by putting in systems that will detect and correct issues that we may not have even known we were doing. And that's kind of the whole goal. So when we can improve clinical behavior, the outcomes theoretically should improve, then there's a bonus opportunity there, and then patient care and performance should get better. The current problem is that there is a lack of patient accountability. And I remember an article, I don't know, it's like 4 or 5, maybe 8 or 9 years ago now, that was in Medical Economics. And it was just, 3 words, will they comply? And it was about patients. And if they're not going to comply, how will we do better? And what will happen is we learn to teach patients about what's going on. We just finished applying for a $6 million macro grant application just today because it got extended. And in that grant, the goal is to move the burden of reporting to patients so that it's not all on the providers, it's not all on the practice. Because at the end of the day, I know what a hemoglobin A1C is supposed to be. I know what a lipid profile is supposed to look like. I know how many urine tests I should be doing on someone based upon their risk stratification. But a lot of folks who are not necessarily paying attention to that because they're busy doing other things, and particularly not our patients because that's not part of their training, if you will, we need to help them move forward. So what we're hoping, and what the feds are hoping, is as the comfort with the program increases, the program will continue to evolve. The stakes are going to get higher, but the stakes are also going to span across private and federal payers so that it becomes even more important that you understand how this system works now. Next slide. So let's take a look at what the bottom line of a practice may look like. If you've got a large practice, you absolutely meet the thresholds, and you're in a situation where you are going to be losing potentially a lot of money. But I'm always surprised the number of docs that the money really is not the primary driver for why they're doing what they're doing. The only reason I say that I'm surprised is most people come out with a fair amount of medical school loans, and at the end of the day, you've got to keep your business running. And I live in New England, and in the Northeast, it's almost a faux pas to talk about money. It's considered gauche. Yet as soon as I get south of the Mason-Dixon line or I move to the Midwest, people talk about money all day long. It's just kind of an interesting geographic norm that is something you have to get used to when you're talking with folks in these different environments. So we've done over 50,000 medical record audits over the years, and money comes up when you're discussing those things because they're usually calling us because there's a claims adjustment someone's trying to make against their business. But if you have a large practice, you're looking at a really large impact when you look at the total amount of money in Part B claims that are being adjusted. And the impact is well north of $500,000. And if you've got just 25 providers, well, you're looking at $133,000. But even a small practice like 5, you're covering the majority of a cost per medical assistant by not participating, or you were actually paying for that medical assistant because you did well within the program. So these figures are based upon that plus or minus 5% adjustment, and non-participation in 2018 will automatically cause you to have a reduction. But just by participating a little bit, you can stay budget neutral. You're still stuck at the 2002 fee schedule, but you won't get nailed. And that is something some people are choosing to do just because it's easier than not participating at all. Next. So, Amanda, do you want me to finish covering this piece?
Cover this if you want, or I can talk about the changes. It's not a problem at all.
Yeah, you go ahead. The slide's coming up.
Sure thing. Yeah. this is just real quick. We wanted to jump in so that you know, or so that folks on the call know, that for MIPS 2018 in general, again, we have another session on this in terms of what's changed, but just so everybody on the call knows, these changes are also applicable to QCDR. So essentially, regardless of whether you're utilizing your data and submitting MIPS data with just a qualified registry for the measures that already exist, or if you're coming in as a QCDR and using Patient360's QCDR measures, or you're co-stewarding with us to create your own measures, these different things have changed for 2018 that you want to be aware of. And we have an entire other session on that. And of course, there's also on the Quality Payment Program site information about these different changes, but we just wanted to bring them to your attention so that you understand basically, essentially what applies to a qualified registry applies to a QCDR as well. So the biggest thing that you want to check out for those changes, regardless of whether you're qualified registry or QCDR, self-nomination, you want to make sure that you're looking at the What Changes Matter and Why blog for 2018, and that's on our website. So real quick, just wanted to, one more time, talk about how more clinical improvement, it can and will occur with the QCDR measures. So a lot of what we're looking at here, providers' modified behavior equals more optimal care. Part of how the QCDR came about, 4 years ago is when we were at our first MIPS lean meeting with CMS, and we were invited to that as one of the few registries that were invited to sort of participate in understanding more about what the MIPS program was going to look like, how it was going to roll out, and what were going to be the role of QCDRs. And, CMS did determine, and we all did, that there was a gap in terms of the types of measures that existed. First of all, there's not enough patient-reported outcome measures, which we're seeing now, especially as a result of applying for the MACRA grant and looking more closely at what's called Measures Under Consideration, MUC, as well as NQF measures. A lot of what CMS is seeking now are outcome measures and patient-reported outcome measures, which is alluding to what Doug mentioned on the other slide about patients having more responsibility and removing or easing the burden off of clinicians. And so part of the sort of creation of the QCDR program, if you will, it's more of a branch of qualified registry in a sense of QCDRs all have to self-nominate and sort of put their measures through, if you will, almost a measure development life cycle, which we'll talk about a little bit more in the slides to come and what that really means. But essentially, when you have measures that are more germane, more applicable, more outcome related, more patient-reported outcomes measures, that's where you're going to see the clinical improvement. The reporting is meant to be a byproduct. So that's essentially supposed to be the spirit of the QCDR program. And that's where they were sensing the gaps with just applying and coming into the program as a qualified registry and submitting the pre-existing cookie cutter measures really wasn't cutting it for a lot of folks. So at the lean event, when we were rolling out in terms of talking to CMS about the MACRA program, that's sort of how the discussions of QCDR came about, and why it's so important to sort of bring more stakeholders in to start creating other measures that are more applicable and that can be benchmarked in related specialties as opposed to the cookie cutter measures that already exist under the quality payment program. So this is that part two that I was telling you about in the beginning of really what it means to report with a QCDR, why it's important. And so let's take a look at this. First of all, for specialized practices. So some of you may or may not have had a chance to look at, you understand that Patient360 is already a QCDR measure steward with the Maine Osteopathic Association. So we already have 7 of our own unique measures that are halfway through their what we call in phase 2 of the measure development life cycle. So they are QCDR approved measures. Some of them are in year 3. And so the next stage will be to move those over into MUC certification and potential NQF certification. It takes a few years to do this, so this stuff doesn't happen overnight. So you are able to look at the measures that we already have. And if you are, sort of one of the specialty practices that are related to our measures, they're great to use the ones that we've already created. Or we're going to talk about later what it means to co-steward with Patient360. But again, just getting back to, it's a really good option. If you're looking at the quality payment program overall, you have to report for MIPS, but you're seeing the measures that already exist, and there's about 243 of them if you're reporting through a registry like ours that you can submit. but there's a ton of gaps. And obviously there are. CMS knows there are because they just put out the ability for groups to apply for the MACRA grant, which is, what is the MACRA grant all about? It's about developing more applicable, better, more useful measures that go through the measure development lifecycle process. And we'll look at that. There's an environmental gap scan analysis document that I want to share with you all in a minute, just to show you how many gaps there are. And so you may be one of those folks on the call that are saying, yep, like, we have to participate in MIPS. We don't want to take the ding, but we really don't want to be reporting on these measures that just, it doesn't make sense for us. And so that's why we're here today, to talk about what we can do to help it make sense for you. I'm going to pause just for 1 second to make sure there's no questions at the moment.
Only one question was, someone asked if you could remind them what MUC stands for.
Yes, it's Measures Under Consideration. And there is a MUC application. There's a separate MUC application. So Tamara, if you just get the email address of the person that asked that, I can actually send them all the links that take them directly to what would need to be done to apply for the MUC, which is coming up. That application for 2018 is due, I think, in mid-June. It's coming right up.
Yeah, it wouldn't be a federal program without acronyms that people didn't understand, because that's right. What they do.
We'll have a glossary next time of like every acronym. But typically what happens, for those of you that are curious about MUC or NQF, the first step, and we'll talk about this a little bit more in the measure development lifecycle, the first step would be to get your measures in as QCDR measures first. And then after that, you would look at moving toward MUC and NQF, because it's like QCDR is like MUC NQF light, if you will. You get the concept and the development, and you start testing it and gathering data. Then once you have more data, so you have to get the data first, then you can move sort of more forward with the MUC certification and that sort of utilizing that platform and understanding how to do it. And same thing with NQF. So we'll talk a little bit more about that in a second. There's lots of platforms and just things to understand and wrap your head around. But QCDR would be sort of the first stage if you're really thinking about developing a measure, moving it through the entire life cycle process from concept to development to testing to implementation. QCDR would be the way to start. And you can see here, I mean, different folks come to the sort of realization that QCDR works for them or is important for them or makes sense for them, for different reasons. I think it really depends on where you are as an entity, as a practice, as a group, what you're looking to do. And again, that last slide, the last helps pain management and addiction recovery specialist. That's if you're utilizing our, one of our 7 measures. But you might say, but okay, that I'm not a pain management. I'm on here and I'm doing something different. So you might want to look at, okay, I need to co-steward, and what does that look like, and how does that feel in order to develop those measures. But these are the sort of whys of sort of why people come to QCDR reporting, because really there's gaps in the regular MIPS measures, and they really want to get their measures on the board now, and also because it takes some time. So if you want to move your measure from concept to development with us all the way through the life cycle, the MACRA grant application itself, think about it, if CMS allows the life cycle phase to be 3 years, that's kind of what they're looking at. And it's pretty consistent with what we've seen in other applications, that yes, you get the measure approved in the initial year and you start utilizing the measure and collecting data on it, but it takes a few years to capture statistically valid enough data to make the measure statistically valid. And then you got to keep testing it and making sure that it's doing what it's supposed to do. So those are some things to keep in mind for QCDR reporting. I think Doug wants to say something as well.
Yeah, I wanted to add one other thing. Within the QCDR, sometimes this is supplementing existing measures. So maybe you found some that you thought would be applicable, but then you can't find others that fit within your subspecialty, or maybe within your specialty you have a particular focus. But in particular, looking at the pain management and the addiction recovery element, lots of different types of providers are doing that. I've met OBGYNs who are doing addiction recovery work. I have met lots and lots of primary care doctors, because if we don't have the primary care doctors in the population, there are even some private insurance companies now paying incentives for primary care doctors to get their XDEA number so that they can have a place to send patients in need of addiction recovery work within their panel. So when we say addiction recovery specialists and pain management specialists, although we may be referencing those specialties, anyone doing that type of work can use these QCDR measures, and you can mix and match with the regular QPP measures, and we're certified for every single one of them and have been since the inception of this program 12 years ago. So it's a kind of the best of both worlds that you may say, hey, I'd like to look at this, but if you're going to look at this particular topic that I want to study or that I think would make a good measure to report upon, the key, and we'll talk about this in a moment, these have to be high bar measures. Medicare is not expecting everybody to pass. I know we're in a land where everybody is supposed to get a participation trophy. That is not what Medicare is after here. So it's important to understand that they want a high bar. The priority is on outcomes-based measures, and that's what they're really wanting us to do. So I just wanted to add that because clinically I think that's important to understand that we oftentimes categorize certain types of care within certain specialty areas, but knowing that in many, many groups it can span the spectrum, and just because a measure is labeled as such doesn't mean that you, whatever specialty you are, couldn't potentially use it if you have the applicable patient population.
Thanks, Doug. That is super important, and that also segues into a little bit more about when we're talking about understanding the importance of the types of measures, them being outcome, as well as looking at the key gap areas in terms of, an environmental scan. And that's everyone that's going to join with the QCDR, if you're planning on co-stewarding, and we'll talk about that in a couple of minutes, would go through this process with us. With Patient360, we would guide you as your co-stewards and what it means to do pre-harmonization, to look at the environmental scan and the gap analysis. And like Doug said, you might want to say, okay, well, there's a couple of the Patient360 measures that we're aware of that we already want to use. And then there's one that we would like to develop de novo with Patient360 as a co-steward. And then there's a couple of quality payment regular MIPS measures that already exist that we want to use. What Doug was mentioning is that you can actually mix and match. So you could potentially co-steward just one measure, because it does take time, again, to do the measures de novo. If there's something that you really, after looking at the environmental scan and gap analysis with Patient360 and determining the measure concept, might want to do one. And then, like I said, another 2 of our QCDR measures might be applicable. And then you might want to do a mixed combination. And overall, you're meant to be submitting 6 measures, quality measures total for the quality payment program under MIPS each year. And so you can mix and match any of those measures, some that could be created and co-stewarded with us, others may not be. So that is something that's much more flexible when you're coming in with the QCDRs, that you can kind of do more and you can mix and match. I think most of you have probably seen these, and so I'm not going to spend a ton of time going through every single measure, but the specifications are actually on our website, the long specifications. And I do want you to be aware of, just so you can understand when you're going through the process, what it means to be working with us. It's not like all of a sudden you have to say, we want to co-steward with Patient360 and we're going to bust out all of these measures together and these specifications. I mean, this is a lot. You have to really understand measure development beyond concept, but what it means to create the numerator and the denominator for what you're looking at. So we work on all of that with you. So we have been through this measure development process on multiple measures. We've gone through the process. I just wanted you all to be able to see, what does an actual measure specification look like if it's not a quality payment program regular MIPS measure, if it's a QCDR measure? What kind of things do you cover? You have to talk about the type of measure that it is first, what successful reporting means. You have to have all the explanations for the numerator and the denominator, and then you have to have lots and lots of citation and rationale. And so these are things that we work on with you if you plan to co-steward. And if not, then the measure specifications, if you decide you want to use one of our measures, these are already coded and ready to go. So you can actually report on these here in 2018 if there's any that work for your entity or organization in terms of current quality payment program measures for 2018. So just wanted everyone to be aware of that these measures themselves are actually located on our website if you want to sort of break them down and take a longer look at the specifications for these measures.
And it's kind of a game to create them. I'm a little bit of a nerd, but I think that it's fun. And maybe I'm a lot of a nerd, I don't know. But it's a really interesting puzzle. Come on. So,
come on now. I'm telling you, we're going to vote on.
So I think that it's important when you look at that. It does seem daunting to some folks to do it, but if you have a topic that you think isn't being measured, if there's a particular clinical bent that your practice or that you personally have, take a look at it. And if you think that you're doing something that should be done that is not, that is affecting outcomes and affecting clinical care that we can measure, let's have that conversation, because it's really not that hard to do per se. So the measures that we developed really came about because of a lot of work that I've done. I've practiced pain medicine and addiction recovery work for the last 2 decades. And in that process, we've done a lot of medical record audits and other things. But one of the big pieces I've done that kind of forced my hand into this regulatory arena is I did expert witness work for the FBI, the DEA, and the Department of Justice in criminal prosecutions of doctors who killed people overriding pain meds. And I don't say that lightly, because I believe that patient accountability and culpability in our culture is probably at one of the lowest points in history. But there are people out there who are doing bad things. And one of the cases I did, a guy killed 68 people over 5 years overriding pain meds and claimed that they were just bad apples. And he was seeing 90 to 115 people a day, 365 days a year, even when he was out of the country. That's a great business model, but it was horrible medicine, and the guy was a criminal, and he and his wife were in prison for 30 and 33 years as a result. So we came up with these measures as part of my clinical practice because I changed what I was doing by watching what was happening in those federal cases, by watching what was happening in my community, by watching what I was seeing in patients who had duped me, and by identifying things that I could be doing to put in a risk mitigation program that had red flags, and that had a risk assessment protocol so that we could come up with methods to improve care and make the practice of pain medicine safer so that legitimate patients were being taken care of. I'm not a guy who likes to play gotcha. I like to help people prove compliance, and in the process, we will detect and correct diversion. That's the goal. So that's where those measures came from. In addition, I'm an osteopath, so there were no measures for manipulative medicine. So we've been working with some of the national chiropractic organizations as well, because in the pain management world, manipulative medicine is something that people think about, but there were no measures to look at the validity of what was being done. I'm not a big fan of continuing to see the person over and over again doing the same damn thing. If they're not getting better, if we're not showing functional improvement, which is a measurable visual analog scale metric, we shouldn't be doing it. And so we created measures based on those issues that I was just discussing, and we worked with the Maine Osteopathic Association to become a measure steward, and these are national measures. Just because it's Maine Osteopathic, anybody can use them, and we use them all over the country. So it's been a really exciting thing to be able to do, but there's lots and lots of work to be done. We just came up with 8 new measures that are de novo measures that we put in this macro grant that are multidisciplinary across a bunch of specialties working in those gap areas. And we're looking at creating an open source data language so people can write their own measures with us in layman's terms, and our database would interpret it for them. There's many, many cool things that we want to do to help people participate in this program. But by getting the measures out there, we can compile analytics that we can begin doing a lot of good study of so that we can show the government, we can show the medical community. These are things we could be doing differently that will improve the quality of care, save lives, and in the end, save money, not just to the insurance companies, but to the system at large, so that patients are not spending extra money and so that we're not spinning our wheels doing things that we don't need to be doing clinically.
Thanks, Doug.
You're welcome.
And, what Doug's saying about there's a lot of options to either utilize your, the QPP measures, one of our measures, or co-steward with us. One of the slides that I wanted to look at now with everyone, okay, well, let's say, okay, I know that I want to co-steward, like, what do I do, right? So you've got in your mind, I want to use one of the QCDR measures that Patient360 already has. I know for sure I've seen it. That definitely applies to us. We want to use that. We want to start reporting on that. That's fine. You can start reporting on that now for 2018. For 2019, what you want to think about. So if you want to co-steward a measure with Patient360, the 2018 deadline has passed. But for 2019, now is the time to actually start planning with us which measure that you want to bring from concept all the way through the measure development lifecycle and self-nominate with Patient360 as a co-steward. So there's a few steps involved in that, and just so that you understand, the measure development lifecycle, I've said it a few times, but I just want to say it one more time. It starts with just a concept, the idea, And that's when you see the different titles of the measures that we were showing you before. So you would hash it out with Patient360 in terms of, I have sort of the seed of an idea of what I'm thinking about doing for a measure. What we then do with you in the concept part, right, as your co-stewards, obviously you work with Patient360. We have a co-steward agreement. It's a standard co-stewardship agreement. Once that's in place, we start working with you to think about pre-harmonizing that measure. So we go through the environmental and gap scan analysis that I was showing you before. We work on that together. We make sure that the concept, the measure that we're looking at and thinking about, isn't already being utilized or it needs to be sort of rejigged. So remember that CMS is also looking for measures that might already exist potentially as a process measure, or they might be they might be getting rid of that measure. It might be topped out, and they're saying, look, this is topped out. This needs improvements. This is where entities like ours come in as co-stewards for QCDR measures and say, hey, look, we're going to take this measure and turn it on its head and redevelop this from concept all the way to development, to testing, and to implementation. And so when you're looking at thinking about, okay, what does it mean to become a steward with Patient360, we work with you to do all of this. So the process of becoming a QCDR, which essentially means you have to submit new measures or de novo measures, or measures that have been very much updated from what they were in the past. What that means is you have to actually self-nominate with Patient360 as your co-steward. So there's an entire process in place for self-nomination. And so and I'll send you this link if anybody's interested. We do all this for and with you. So every year you have to take the measures that you're looking at developing, and you have to actually submit and self-nominate. And this is where Patient360 comes in as your co-steward partner, because we're already a QCDR and we do this for and with you. So this is really important stuff to be aware of if you're thinking about this process. It's actually not that hard. It's pretty clear cut because we've done it a million times. It's the timing of it. We want to make sure that if this is something that you want to do, even if it's for only one measure, you want to start the concept process with us and getting the co-stewardship agreement in place this summer, because the self-nomination for the measure itself, that takes place in the fall of 2018. So that way, once it's approved, you're ready to start reporting your new measure that you've created with us at the beginning of the reporting period, January 1st in 2019. Does that make sense? I just want to see if anybody has any questions on, hey, I'm ready to co-steward. I want to walk off this call knowing exactly what I need to do and how I need to do it.
And I think, Amanda, just to echo your point, it sounds a lot more daunting than it is, because some people are like, well, I don't know if I can do it. All you have to do, to Amanda's point, if you have an idea that you think we should be measuring that isn't measured, that isn't available in the QPP, we'll walk you through these other pieces, because to Amanda's point, we've done this dozens of times. It's just about finding that measure, that topic, or that area of interest, and that's really what it comes down to. But
yeah, this is a process that's been in place for quite some time for us, and so that's what we do as your stewards, as your co-stewards. We walk you through the process and say, this is what we need. But mostly from our co-stewards, it's the concept. It's really the concept, because we then take that concept and move it to phase 2, into development, into test, implementation. That's all by Patient360 when we're your co-steward. And Tamara, were there any questions at the moment?
You were able to weave them all in, Amanda.
Great.
she's good at that.
Yes, she is.
Most of the time. I'm an East Coast talker, though, so I talk fast, so I'm trying to be real slow. So just real quick, going back to registry reporting in general, just because it's important to know that, there's these analytics that exist that you're seeing. There's even more if you're doing a QCDR. So you're getting, as Doug was saying, like you can mix and match. So if you come in as a QCDR with us, let's say you may or may not develop a QCDR measure with us. You might use one of our 2, 3, 4 of our 7 measures, and then a bunch of the other regular MIPS measures. You have access to all 240 of them, plus the specialized QCDR measures, plus for 2019, if you co-steward, whatever you've developed with us. So there's opportunity, and you're going to get all the same feedback and analytic tools and the dashboard and all that good stuff that you would get if you were qualified registry with us as well. So you get all of the same analytic tools, and I think that that becomes exceedingly important, especially for QCDRs. And also level set. It doesn't happen right away in terms of if you create a new measure or you report your data with us initially in the first year or two, and I think that it's important to be candid about this, because sometimes folks are like, I really want to get bonus. Initial measures, every measure has a measure development life cycle. It's typically about 3 years because you've got to get lots of data on it in order for it to be benchmarked and to be put in physician compare and all that jazz. So initially, and being candid, yes, it's going to, if you pick one or two of our QCDR measures or you develop one with us, you're going to get points for it, but you're not going to get the maximum benchmark points yet this year or in 2019 because it's not benchmarked yet. It's got to go through the life cycle process. And so that is just managing folks' expectations that you may want to in the first year that you're doing QCDR so that you can still get lots of points is say, you know what, I'm going to do 4 MIPS quality measures that already exist that are outcomes that I know we're doing really well on so I can get a lot of points for those. And then I'm going to submit 2 or 3 additional QCDR measures, even though I know I'm not going to get maximum points for those measures because they're not benchmarked yet. It's really important because in year 2 and year 3, once they start benchmarking and once data is captured across multiple specialties, they will receive a benchmark and you will get additional points for those measures. So that's just something to keep in mind in terms of the timeline, that it doesn't happen overnight, and it's very simple on our end because we walk you through it and we've done it a million times, but I do like people to know that all of a sudden, if you create a measure in 2019 and you're submitting all of your own data on the measure and you're doing really well, that doesn't mean that you're going to get the full 10 points for 2019 that you can on that measure because it doesn't have official benchmark information loaded yet to CMS. So that's just something to keep in mind for the de novo measures. For, I think, 4 of our QCDR measures just got benchmarked. They're in physician compare. So folks will probably be scored on those in 2018, those reported in 2017 for those particular 4 measures that had enough data to be benchmarked. So that's something to keep in mind. So another important thing when we're talking about, oh, okay, I know that I want to be a QCDR or at least use the QCDR measures that already exist or co-steward or a combination of all or both. I think what's really important to know is, well, then how the heck, once we are a QCDR, how do we get the data to Patient360? How do we get this measure information that we've been capturing to them? So there's a number of different ways. Same ways that you would get the quality payment program MIPS data to us, the existing measures, right? Because our QCDR measures, those are all coded and specified. What's important to keep in mind, the API is probably the easiest way, the API endpoint. So we have our own API endpoint plus CMS has an API. That's going to be a real easy way to get data to and from in terms of interoperability. A lot of folks have QRDA3 files formats from their EMRs or EHR, which is great. If you have regular quality payment program MIPS measures, those can easily just, the QRDA3 file just goes right into our system and provides you with a dashboard of your scores and everything. For QCDR measures, what you want to keep in mind, and again, this goes back to advanced implementation, which we are at a good place because if you're thinking about, again, creating a QCDR measure as a co-steward with us for 2019, now is the time to start doing that, because what that means is there's going to need implementation of the QCDR into your EMR in order to export the QRDA3 file format. So basically, you have to have the measure information in your EMR so your providers are asking the questions that they need to be asking by the time January 1st rolls around. So they're answering those questions so that the QRDA3 file can be exported. So that's what we mean when we say you have to have data in your EHR in order to export the data. You can only get the data in your EHR if you actually have the measure that you want to use and the questions associated with that measure somehow into your EHR. And so the time to be doing that simultaneously with, developing the measure and everything is working with Patient360 to get that measure into your EHR so that you could use the QRDA3 file export if you wanted to. So those are just things to keep in mind. The templates are easy as well. Many folks use those. What happens with the QCDRs for templates, you're a little bit delayed. So unless you're starting early, again, you want to be able to do some sort of SQL query or something in your system to be able to pull the data, but you have to be capturing the data first. And because these QCDR measures are new, you're creating them with us, you have to make sure they're in your system so you're actually capturing data on those QCDR measures. Does that make sense? Does anybody, I'm going to pause for a second and see if anybody has questions on that. Because I know sometimes,
Yeah.
the speakinese when it comes to like developer, I call it developer speakinese. It sometimes sounds like Klingon when you're thinking about all these ways of interoperability.
You're good, Amanda.
Okay. So one final time, regardless of whether you're using our QCDR measures that already exist or you're creating a new QCDR measure with us, now is the time to start talking to us about that so that we can make sure the information about that measure, either one of our 7 measures or one that you're going to create with us, that we start getting that loaded into your EHR or your practice management system now, so that by the time January 1st rolls around, your providers can actually report on the measure because it exists in your system. Else, measure if it's not in your actual system. So that's something to keep in mind, and that's why we're having this presentation now, because we want people to have the entire summer to work on the concepts with us if they want to develop a de novo measure, and then we can work in the fall on getting it implemented into your EMR system. Everybody, regardless of whether you're with us as a qualified registry, a QCDR, if you're using our own QCDR measures, if you're developing QCDR measures with us, same type of dashboard. So there's lots of analytics available towards your final score for QPP. You'll be able to look at your entire group practice. You'll be able to break down the measures by group practice, by provider, so you can look at how your providers are scoring against each other in the TIN, within the TIN if you want. We're also certified to submit improvement activities and ACI measures, which is now promoting interoperability, as most of you have probably heard. For 2018, it's just a change in name, and there'll be an entire other session on what's changing between the ACI/promoting interoperability for 2019. But just know that we report on all of the categories under MIPS for folks that are required, which are the improvement activities, the PI, and the quality. And QCDR, just to reposition everybody, QCDR are quality measures. So when you're developing measures with us or using one of our QCDR measures, that's for the quality category. And so the dashboard is going to tell you over time how you are performing. It's going to compare you against the national benchmark if there is a national benchmark. So it's going to show you how you're scoring against the national benchmark and then what your final score is. We are also tapped into the CMS API developer sandbox, as well as we did all of our submissions this year through the API. I don't want to get into too much developer talk about that. Safe to say it's the first year that CMS launched their own API for folks to be able to submit, for registries and QCDRs to submit. And the beauty of that is that folks the submissions go in so quickly, and you can see immediately what your scores are. Now, that doesn't show special scenarios yet, but it's pretty far more efficient than it ever was doing file uploads. So just know that Patient360 utilizes that API submission mechanism, and we also have our own API mechanism for submission for interoperability. So that's something really important to keep in mind. So we offer all the registry measures, as you know, the 7 QCDR measures, all cases and categories, as I just mentioned, so improvement activities, promoting interoperability, and the quality category, 7 QCDR measures. We also have a helpful measure selector. I find that folks are really, really getting a lot of use out of the measure selector. That's one of the best things, because what happens is if you're not developing QCDR measures, but you are, let's say, using the MIPS quality measures, and you're thinking, well, I know I need to find 6, but I'm not sure which 6 are the best for me. We actually have in our portal a code selector, and that code selector allows you to type in, your most frequently used CPT or ICD codes, and then it will reveal to you the top measures that actually quality measures that apply based on the CPT codes and ICD codes that you're using most frequently. So that's been really, really helpful for folks that are brand new to the program or just don't know a lot about measures themselves. The data entry, like I showed you on the previous page, there's like 5 different options now. A lot of folks are starting to use the QRDA3 file upload option because we roll those up into a group for you. So you can, and then we submit them as the group for you if you're a group practice, so it makes it really easy. It's fast. It takes no time at all to pull a QRDA3 file from your EHR if your EHR produces QRDA3 files. So that's become really popular.
And most should.
Yeah, exactly. What they do though, Doug, a lot of them only produce individual QRDA3 files, and then what we do is roll it up for you into a group file and submit that for the group entity. So it's been a big success. We have an optimizer for that too that optimizes, from the entire group roll up the top 60% of data. The one-click and submit to CMS, again, that's the API submission. It has really changed the submission process. It's really that fast. And then you get to log in to the QPP website and see the submission immediately. And like I said, they show your points, but not special scenario points. So if you have like a hardship or some other special scenario that applies to you, they reallocate those points in and around about July. So for folks that submitted with us in 2017, they're seeing like their core basic points about what they're going to achieve. And then in July, they get their final score, which will show essentially any special scenarios they had. The cool thing about our dashboard is that we actually showed the special scenarios and points to you in advance before CMS does, because we actually developed and built that out first. So pretty much what you see on our dashboard is what your final score is going to end up being with CMS, which is fantastic. So you get an earlier glimpse as opposed to having to wait for CMS. And again, the analytics is what we're all looking at. You know, you want to know how you're doing, how is this impacting your outcomes? And by doing the reporting like we're talking about now, coming up with measures now, if there are issues in January, February, and March when you start reporting and aggregating the data and taking a look at the dashboard, and it's like, oh, provider X is really struggling with this measure, you have time throughout the whole reporting year to still make improvements and make changes and clinical improvements. So that's something that's really important. The earlier you start in this program, you know, the more of a chance you have of making the improvements during the reporting year. Because a lot of folks are like, whatever, I'm just going to report at the end of the year and retroactively submit all my data. You can still do that. I mean, many people do because they're just trying to avoid the payment adjustment, and that's fine. I mean, it's not necessarily the spirit of the program, but some folks are like, you know what, I don't have time for more than just avoiding the payment adjustment. And if that's the case, a lot of them will just retroactively go in and pull the QRDA3 data or pop in the templates at the end of the year, and your score is your score. But that's the thing, your score is your score. You can't make clinical changes or improve anything if you're not submitting your data until the end of the year, right? So it really depends on what angle you want to take and what you're looking to do as a practice. If you want to get bonus, then you want to start getting your data in ASAP so that if there are gaps or issues, you're addressing those within the reporting year and making the improvements. Does that make sense to everyone?
And I would add it optimally, if you can do the QRD3 multiple times throughout the year, what the optimizer does that a lot of other places don't do is we're able to go in and by optimizing, what we're saying is you only have to report on all patients, what CMS defines as all. It means your Medicare patients, your cash paying patients, and your private paying patients, but you only have to report on 60% of them for that to count as all. Our optimizer can tell you which 40% we probably should remove so that your 60% are optimized. And that is a bit of gamesmanship, but just like the E&M billing and coding world, you got to know the rules in order to win the game. And so we put a system in place, and we can take that data in that format, and we can do that analysis. So that's a pretty cool thing.
Exactly. And I mean, again, it's all what you're looking to do. I mean, what we try to do is provide that balance for everyone and say, look, what is the actual written statute, which is report on 60% of your patients, and that's the statute, right? And so, but on calls, what we also share with our clients and everyone is what CMS would like for the spirit of the program is for you to report on everyone, because that will really give you a better indicator on where improvements need to be made. At the end of the day, we're working with you as the clients to follow exactly what the statute says, no more, no less. If you decide that you want to report all your patients, we're going to support that, and you can report on everyone and everything, and the scores will be the scores. If you decide that you want to just follow statute to the T and report on the 60% for the optimized score, that is technically okay to do because that's statute, and we're going to support. We work with you to try to do what it is that you're looking to do, whether you want to remain neutral or go for bonus. As long as it's within statute, we will be working with you on that. And so we have those conversations with you. We're very candid about what CMS expectations are versus what's written in statute, and sort of we create that balance. We kind of give you the pros and the cons of everything. So where are you in the process? Folks that are on this call right now, okay, if you are here in 2018 and you haven't done anything yet, the best thing to do is to get started at least with our qualified registry, getting some NIPS data in, because understand that here in 2018, they've given us another break. And that is, if you can get at least 15 points submitted for 2018, you will avoid the payment adjustment. So if you're really scrambling right now and you have no idea what's going on, at least get a few measures in, and there's our MIPS for Beginners program. It's really easy. It will get you to that 15 points so that you can avoid the payment adjustment. While you're doing that, that's when you want to now start thinking about too, well, okay, I'm going to avoid the payment adjustment in 2018 if I start reporting now and just report a little bit, just get something in up to 15 points. We'll work with you on that. And then you also may want to start thinking about if you want to co-develop some measures or use our QCDR measures, let's start getting those into your system now. That's what you want to talk to us about now as well. So that's how it's going to work. You're going to sign up with Patient360. You're going to get your clinic information into our portal. You're going to decide if you're reporting individually as a group. Honestly, anybody over 2 in a TIN, that's what everybody does now. It's a group. You're not, very rare and very specific circumstances would you see a group of, say, 10 or 20 having all of their providers report individually under the one TIN. It is possible. We can do it. But we will usually talk to you about why you want to do that first, because typically it's somebody was misinformed. Because most folks, if you have more than 2 in your TIN, you're reporting as a group. It's way easier. So that's just something to keep in mind. And then you're going to select your measures. So again, you have the option to just do the MIPS for Beginners program, get your feet wet right now in 2018. If you already have a few measures picked out and you say, but I also want to add in some QCDR, let's get those started as well. And then you want to think about development for 2019 as well. So you're kind of doing both things simultaneously if you want to stay on top of the game here. Data collection. If those of you that have not started the program yet, like I said in the beginning, technically you can collect data all the way at the end and just put it in retroactively. But just remember that there's not a lot of time to make change or impact during the reporting year. But if you decide, all right, but it's halfway through the year, I'm gonna retroactively go back in and pull all my data from January 1st, dump it in the Patient360 portal and continue to report throughout the year, that's totally fine to do as well. And a lot of the changes, I mean, you still have 6 months to make improvements. So, I mean, there's still plenty of time for here in 2018 if that's what you're thinking about doing. And then again, my pushing the 2019 is more for you guys to think about if you want to co-develop measures or you want to use some of our QCDR measures. We want to work with you now to try to get that into your EMR system to make interoperability easier for you. And of course, upload early and often. That's our mantra. But again, we have folks that do it multiple ways. Some folks are early and often. We have clients that are in our portal on a weekly and monthly basis submitting data. Others still submit at the end of the year. And again, we work with each client on an individual basis to decide what works for them and why and what they want to do. And we go with that. So your next steps, go to patient360.com. You want to select your reporting option. There's a bunch of different packages that are listed, whether it's MIPS for beginners, you can do the intermediate package, there's QCDR. You're obviously going to speak to one of our representatives. More than likely, it'll be Heather. She'll reach out to you if you haven't already connected with her yet to talk about the sign-up process with Patient360. And then it's going into the portal and beginning reporting. I mean, it's a pretty easy process. And again, I know the co-stewardship thing sounds like it's this big, crazy thing, but we pretty much do all that for you. I mean, we kind of tell you step by step, okay, now this is what we need, your measure, concept, and idea. Okay, now we need you to sign the co-stewardship agreement. Okay, now we're going to go in and we're going to do the self-nomination process, and here's the information that we're going to complete. And essentially, it's just a checklist that you're receiving from Patient360. And then you get notification once the measure has been accepted, and we're your co-stewards, and it's publicly posted on the QCDR public posting, and I can show you where that is in a minute. So it sounds like it's daunting, but we've done it a million times. It's really not. And then the beauty of the whole thing is, if we do co-steward a measure for de novo, like I said earlier, that's then going to go into the measure development lifecycle phase. And if you're interested, as an entity, we'll move it over to the MUC and to NQF endorsement. So that's an option as well. So there's a lot of cool things that are happening now. I mean, as cool as anything can be under, for MIPS. I mean, I wouldn't exactly call this a cool program, but probably the wrong word to use, but a lot of things that are better than slightly better than they were before anyway. Yeah. So it's not super difficult, and we're here to sort of walk you through that process, and that's why we held this earlier than later, this particular presentation on QCDR specifically, so that folks know you can still report our QCDR measures now that already exist, and you can mix and match them. And if you want to create a new one, now is the time to do that with us, so definitely contact with us about creating a new one if that's something that you want to do. So with that, I think we have a little bit of time left for questions, anything that we may have missed. Please let me know. I'm going to pause and hang out for a couple minutes. See.
Hey, Amanda. You were able to answer all the questions, and we are actually at time right now. So unless there's anything else that needs to be added in, anything from you?
I think just encouraging folks to do the survey and let us know if there's still something that you don't understand about what a QCDR is or how to actually go about doing it. Let us know so that we can, again, continue to walk you through what that process looks like and what your next steps are. And Doug, anything else to add?
No, I appreciate everybody's time, guys. Thank you for joining us.
Thanks so much, everyone.
Thanks, everybody.
Have a great
Bye-bye.
day.